Assalamu alaikum, it's me Dr. Naseem Shirzad. Today I'm going to discuss with you all radical prostatectomy, and before starting radical prostatectomy it is important to understand some basic anatomy and the surgical anatomy of the prostate. Actually the prostate is the having a base and apex. Just to make it very simplified, it's having a base which is in a connection with the rectum, and the rectum is separated from the base of the prostate that by the adenovular fascia, and then the prostate having an outer covering which is called the levator fascia, prostatic fascia, and there is another covering that is outside the prostatic fascia, and that is called the levator fascia. So if we just and the prostate having base, and that is apex is at 12 o'clock and the base is 6 o'clock. So at 12 o'clock it having DVC, means deep venous plexus, which is also called prostatic plexus, also called centroneal plexus, right? And the other important thing is the base which is having pipe and 7 o'clock. The pipe and 7 o'clock is surgically important because this area contain neurovascular bundle like your nasal nerves, and it's important if you are going to for nerve sparing, our intention to save these neurovascular bundle like the nasal nerve, and means to prevent the erectile dysfunction. So it's important. And the 12 o'clock having DVC, that's why like in uroleft procedure or any other procedure like in prostate, our intention to limit ourselves to the anterolateral wall like 2 to 10 o'clock. That's why we are applying uroleft clip at 2 and 10 o'clock, because the neuromuscular bundle is far away, the deep venous plexus is far away. So we can keep the patient at risk if we applied much more dorsal lateral where located the neurovascular bundle. So it's important. The 12 o'clock, the 6 o'clock is base, and on the each corner is located at 5 and 7 o'clock, means the posterolateral, the neurovascular bundle on the top at the apex, that is 12 o'clock where deep venous plexus is located, and then the prostate is covered by our outer covering called the prostatic fascia, and then the another outer covering, that is the levator fascia, and the neurovascular bundle located between levator fascia and that is the prostatic fascia, right? So now coming to the radical prostatectomy, what are the indication of radical prostatectomy? Radical prostatectomy indication, this is a proper treatment for a patient of intermediate and a high risk patient, but important the patient should having a life expectancy more than 10 years. Now which approach can be used? So we can use do it through robotic assisted, which is a gold standard, laparoscopic, and can go for open surgical procedure. But the end that the functional and oncological outcome are comparable. Laparoscopic and robotic assisted, one thing which is very important, that in laparoscopic and robotic assisted we are actually performing a pneumoperitoneum, so there is a less risk in laparoscopic and robotic assisted of bleeding as compared to open procedure. As I mentioned that the positive margin during radical prostatectomy, that is the apex. The complication is also important, early complication and late complication, and early complication, bleeding, infection, mortality in less than 1%, rectal injury. But later on, the patient can develop impotency, which is 40 to 60%, stricture and stenosis 10%, and incontinence mild and 50% at 1 year, and after 12 months that's increasing around 70%. The impotency, patient can develop impotency, and that can be treated with phosphodiesterase inhibitor. Now what are the contraindication to nerve sparing injury and radical prostatectomy? When the disease is palpable, don't go for nerve sparing surgery. When there is a high Gleason score, don't go for nerve sparing radical prostatectomy. And when you are thinking that there is a higher chance of capsular death, so don't go for radical prostatectomy. But again, the neurovascular bundle, as I mentioned, that's located between the prostatic and levator fascia. Now coming to the adjuvant and neoadjuvant, that's asking a lot of an exam, and let me to clear it very in easy words. Neoadjuvant hormonal treatment before radical prostatectomy can reduce the prostate size, and that can reduce the bleeding, and it can also reduce the positive surgical margin. That's important for basic use. That the importance of neoadjuvant is that it reduce the prostate size and positive surgical margin. But as we know that the overall cancer pre-survival rate is low, that's why it is not recommended. You should have in mind that radical prostatectomy, before radical prostatectomy, neoadjuvant can reduce the prostate size, can reduce the blood loss, can reduce the positive surgical margin, but as it having no improvement in overall survival, therefore it is not recommended. Now coming to the adjuvant. Adjuvant means after the surgery. So after the surgery, we will be looking into the biopsy report. If it is an N0, means there is no lymph nodes involvement, so no therapy, no observation is needed. But if the patient is having N1 or N2 or N3, so what to do? So if the patient is having N1 or N2, we can offer two options: ADT alone or ADT with radiotherapy. So for N1 we have two options: only ADT or ADT in combination with radiotherapy. We having another option of observation. So which patient within positive lymph nodes we can observe, that's must be having less than or equal to lymph nodes, and the PSA should be less than 0.1 nanogram per ml. So per lymph nodes, if 0, no observation, no therapy. If it is positive, offer the patient ADT alone, ADT with radiotherapy. We have also observation option in case of positive lymph nodes. If the patient is having less than or equal to 2 lymph nodes and the PSA level is less than 0.1 nanogram per ml, we can option them as the observation. Now one thing another is important, that how to follow the patient, and just talk about some biochemical recurrence. But before going this, let me mention that what was the intention of this radical prostatectomy. Your intention is trifecta and pentafecta. Trifecta means to make the patient living cancer free, restoring urinary incontinence, resuming sexual activity. These three means trifecta of prostate cancer survivorship. And pentafecta means 5: negative surgical margin and absence of surgical complications. So 3 and 2 is equal 5. So this is your aim of surgery, this is your intention of surgery. Now coming to the biochemical recurrence. Biochemical recurrence after radical prostatectomy is important. Biochemical recurrence simply means, in simple words, means the rise in PSA after surgery in the absence of distant metastasis. It means it occurred just because there is a rise of PSA after surgery, and this is very unfortunate for the patient, and this is because of the micrometastasis. If you just perform the bone scan etc., that will be normal, there will be no distant metastasis. But for radical prostatectomy, after surgery, when to repeat the PSA? We will repeat the PSA after 6 to 12 weeks, I mean 3 months after surgery. If that is more than, if that's not dropping, it's persistently rise even after 3 months or 12 weeks, it means the disease is persistent. This is not, we will not call it actually the biochemical recurrence. So if the PSA persistence even after first visit of 12 weeks or 3 months, then we will call it persistence rise in PSA. So how to treat it? These patients should be treated with salvage radiotherapy, right? So salvage radiotherapy plus ADT, but make sure that there is no meds. So per persistent rise in PSA means more than 2 nanogram per ml post-op after 3 months, we will offer the patient salvage radiotherapy plus ADT. Make sure that there is no meds. Now coming to the biochemical recurrence, this was for resistant rise in PSA. For biochemical recurrence, we will be repeating must 2 sample, and that should be repeated 24 months after the surgery. If a patient having persistently rising PSA means 2 PSA that is greater than or equal to 0.2 nanogram per ml followed by a single confirmatory PSA, we will label them as a biochemical recurrence, right? And that should be repeated after 24 months. So after 3 months after first visit, if it rise detectable PSA, we call it that is persistent rise in PSA. If it rise I means after 3 months the PSA is normal, but it again rise after 24 months, we will call it biochemical recurrence. Now if a patient develop biochemical recurrence, we will divide that patient into two risk stratification. We will actually perform the risk stratification, low risk and high risk. Now, if after radical prostatectomy, if the patient PSA density doubling time is more than 1 year and his pathological grade is less than 4, we will advise the patient PSMA PET scan because it can even detect the cancer even a very low PSA. If that is M0, then we will observe the patient. It is low risk. Low risk means PSA doubling time is more than 1 year, right? Grade is less than 4. There is no meds, so we can observe the patient. Now, if a patient is having PSA doubling time less than 1 year, means it's very quickly become double, or the pathological grade is more than 4 year. So better to offer this patient early salvage radiotherapy plus ADT, and if the patient refusing radiotherapy, you can offer him only ADT. So this was all about biochemical recurrence, and a lot of question on this in every exam, and this is the overall scenario of this prostate. Thank you.